Hello, mateys throughout nation. We're going to be talking about liver disease, the silent epidemic, and many of you have it out there. 1 in 4 people in a modern day city, I believe, has liver disease. And in my practice over the last 25 years, it's exponentially increasing. As a physician, I've never seen numbers like this. We're going to be talking about NAFLD and MASLD because the terminology has changed. And I've got a gastroenterologist and a hepatologist here, Dr. Ibrahim and Kristin Kirkpatrick, who is a very qualified and very expert when it comes to liver and skinny liver. They wrote a book and I've been following their work. I'm so excited to have them on the show. So welcome.
Thank you so much. We're so excited to be here and have an opportunity to speak with your audience.
Brilliant. And
Indeed.
Regenerative Health is the name of my clinic for the last 25 years. You've got a book called Regenerative Health, Discover Your Metabolic Type. So we're going to be discussing that and renew your liver for life. It's an incredible read. And one of the greatest things, and we're going to get into it, is these net carb charts at the back of the book. You got a liver risk assessment at the back of the book, which is just, you got to buy the book just for that. It's so powerful and a wonderful addition at the end of the book. So congratulations to you. I'm going to jump right in, and maybe this would be possibly for Dr. Ibrahim. Why is liver disease, or NAFLD or MASLD, and maybe you can explain the terminology, so important to diagnose and then to treat?
NAFLD, which stands for non-alcoholic fatty liver disease, or the new name MASLD, which is metabolic dysfunction associated fatty liver disease. As the name implies, it's fat in the liver. It's fatty liver. If you take a picture of a liver of somebody with fatty liver, you will see, like, whitish liver. You will see fat in the liver. And it's very important because, number one, it's very common. Believe it or not, 1 in 4 individuals worldwide has been affected by fatty liver disease. Just think about that for a second. 1 in 4 people have fatty liver. It's very common problem, and it can lead to liver damage, liver cirrhosis, liver cancer, and it's the leading indication for liver transplantation in the Western world. So it's really important problem to recognize.
Okay. Do you want to add there, Kristin? Because I think this is one of the most important, parts of the show, is because a lot of people don't know, as it's the silent epidemic here that's happening. Why is it so important that people diagnose this and treat this?
So I think when we look at the liver takes quite a beating before it gives any symptoms. Really, in the first stages of fatty liver disease, you're not going to have any symptoms. You're not going to have any of those warning signs that you normally would, let's say if you have a heart problem or something related to that. So what happens is it gives the liver an opportunity to really progress in the disease. And once you progress, you don't have it in a state where it's longer reversible. I think, when we look at the prevalence and we look at insulin resistance, type 2 diabetes, all these things that affect it, that really speaks to the changing of the nomenclature of the name as well, right? So really taking it away from looking at just this non-alcoholic to now we know there's some sort of metabolic dysfunction going on. That's a huge chunk of us. We're not going to get a warning signal. So that's why we have to be a little bit more proactive if we have any of those risk factors to begin with.
Okay, so that's changing to metabolic associated fatty liver disease, which implies then you cannot have fatty liver without actually a metabolic syndrome or a metabolic problem. Is that correct?
Yeah, so at least, go ahead, Dr.
I'm sorry, Kristin, go ahead.
No, I was just going to say, at least having some component puts individuals at risk. Dr. Ibrahim can also talk about the genetic risk. Of course, we always have genetics with any disease. But what we see in my practice is if your waist circumference is a little higher and any of your metabolic numbers are off, let's say high triglycerides or your hemoglobin A1C is a little high, you're much more likely to be at risk for that. That's what I was going to say. Yeah, please add to that, Dr. Ibrahim.
Yeah, no, I was going to say, yes, for sure. The most common cause of fatty liver by far is metabolic syndrome. Hence the name metabolic syndrome associated fatty liver disease. It's important to keep in mind, though, that there are so many other causes of fatty liver. Drinking alcohol, for example, particularly to excess, can lead to fatty liver. Certain medication can cause fatty liver. Celiac disease or gluten allergy can cause fatty liver. like Kristin said, there are some genetic liver disease that are associated with fatty liver. Now, put that aside, by far, the most common cause of fatty liver is metabolic syndrome, which include, overweight, type 2 diabetes, high blood pressure, high cholesterol, obstructive sleep apnea, those kind of things that set the stage for metabolic syndrome, which lead to fatty liver disease.
Brilliant. So let's just get the nomenclature correctly. Is it metabolic syndrome associated fatty liver disease?
Actually, if you want to be accurate, it's metabolic dysfunction, which is kind of metabolic syndrome, but the scientific word for it, metabolic dysfunction associated fatty liver disease, or the medical term for fatty liver, they call it steatotic liver. That's why you see now the new term called MASLD, MASLD, standing for metabolic dysfunction associated steatotic liver disease, or to put it in lay language, would be metabolic syndrome associated fatty liver.
Okay, got you, which is really, really important. But what you've now said is there are other causes. You could just be a celiac patient and get fatty liver disease. You might not have any of the signs of metabolic syndrome. You might just drink a lot of alcohol and then get a fatty liver. You might not have metabolic syndrome. So there are some caveats even to the name itself.
For sure, yeah, absolutely. Excessive alcohol intake can certainly cause fatty liver. Celiac disease is well-known cause of fatty liver disease. Certain medication, amiodarone, which is antiarrhythmic medication, commonly used in the cardiology world, can cause fatty liver. Methotrexate, for example, which is commonly seen in rheumatology practice for rheumatoid arthritis, etc., can cause fatty liver disease. But like I said earlier, metabolic syndrome remain by far the most common one.
Okay, that's really, really important. So this waist to hip ratio, would you say someone's listening and saying, oh my goodness, I don't know if I've got this or not. Do they look at the waist to hip ratio? Do they look at waist inches? Because someone has to say, okay, hang on, I want to have a good idea whether I've got to go to my physician and do some tests. A lot of people don't have the finance to do the labs. So what do you think the number one sign or symptom for someone listening out there watching on YouTube to get a good indication where they might have this disease?
I think waist circumference, if that's your only solution and you don't have it to be able to go and check your blood sugar, is going to be probably one of the best assessments to it. It's not a guarantee, of course, but we do know that when our waist circumference is higher, the fat within the midsection is very metabolically active. It's very inflammatory. There's a lot of things that could lead from having excess fat in that midsection. And of course, we're talking midsection versus like the thighs and the butt. Right? So it's like, we know that certain fat is very metabolically active in terms of where it's placed. So that's why we look at waist circumference to be even more ideal. I would say as a dietitian, I'd want to see the blood sugar as well, just to see, okay, do you have some insulin resistance going on too? Because that makes that risk factor so much greater. But I think that's the most important thing for me. And, it's really crazy when I was talking to my patients, many of my patients say, well, like, how do I actually do this? I don't have a tape measure. And so I've often joked that most women in my practice have some sort of old pair of pants in the back of the closet that they're hoping to God to get into one day. And that's sometimes a great assessment. So how are you doing with trying to get into that old pair of pants? Is it more impossible? Is it easier? So there's ways to try and kind of determine, am I carrying too much in that midsection?
Okay, but now you're saying just waist circumference, not waist to hip ratio, because from what I understand, one of the diagnoses of metabolic syndrome is waist to hip ratio being under 1. Is it the ratio or is it the circumference?
So in our book, we used a generalized waist circumference. Of course, we do have studies looking at waist to hip ratio. I think, at the bottom line is they're both much better indicators than BMI, which is what we used for so many years to try and diagnose someone as being obese or overweight, and even to the latter extent of healthy or not healthy. So for us to try and make it easy, we just focused on the waist circumference because we thought it was an easy measure for individuals to do within their own home.
Okay, brilliant. Dr. Ibrahim, if someone, and I want to get into the liver enzymes and I want to get into GGT, gamma-glutamyl transferase, because I've never seen numbers increase to such a degree in my 25 years as a physician. I do want to talk about ALT, ALP, GGT, and the liver enzymes. Is it diagnostic if someone does, because I'm just thinking of a pinprick ever in the future of a GGT saying, if you've got a high GGT, then there's a good chance you've got fatty liver disease?
Yeah, great questions. Quite honestly, the problem with those liver enzymes, as you know, they're not very accurate. It's not uncommon for me to see someone with fatty liver in my practice, yet they have relatively normal liver enzymes, normal ALT, AST, and GGT. And the opposite, sometimes you see abnormal liver enzyme, which indicates the presence of fat in the liver, yet fatty liver disease isn't too bad. So the point I'm trying to make here is that the liver enzymes, while we use them for screening because they're easy and relatively cheap, they're not very reliable way to diagnose fatty liver disease and to assess the severity of liver disease or to follow those patients over time. I still recommend them. That's what I kind of, screen for fatty liver. If someone has metabolic risk factors, such as diabetes, high blood pressure, those metabolic risk factors, I tend to get liver enzyme, liver profile, which, as you said, include ALT, AST, alkaline phosphatase, total bilirubin, albumin, and total protein, and GGT. And I like also to get picture of the liver, just to put things together, the blood test plus the picture of the liver to see if there is fat in the liver on imaging.
Okay. But if someone has got, what are the chances? The reason I'm saying they go to a physician, they can do the labs, sometimes easily, but they can't get a picture of the liver. If those enzymes are really good, and maybe you want to comment on, having done functional medicine 17 years now, GGT units per liter, when I started was like under 20, I think, or under 30, some of the labs. Now some of the labs are saying under 40. Some of the labs are now even saying under 60. So I'm really confused why these labs are changing, and they really are quite diverse, and it's not giving I think a very good picture, because the sample groups out there are so sick with regards to their liver. What's happening with these ranges, and what is your recommendation? Someone with a GGT of 20 versus someone with a GGT of 59, and then the physician looks at that ratio and says, "Oh no, you're fine." Meanwhile, they're sitting just on the border.
Yeah, no, you're bringing a really good point. Yeah, it's unfortunate reality that the range of those liver enzymes, not just GGT, but more importantly ALT, which kind of I rely on all over the place. It depends on the labs you go to. The range can be from 25 to like 60, 70. And that's for that particular reason, the guidelines by the American College of Gastroenterology and the American Association for the Study of Liver Disease came out a few years ago, and they said, you know what, it doesn't matter, the range. It doesn't matter what lab you go to. They set up upper limit normal for ALT. They focus on ALT rather than GGT. And the upper limit normal was 25 for women and 33 for men. So technically, if the ALT is greater than 25 for women and 33 for men, it doesn't matter which labs and which range, there is something abnormal, and you got to follow up with your doctor about it.
Now, why did they use ALT, Dr. Ibrahim? This is very important. Why did they use ALT as an indicator more than GGT?
The reason why, because a GGT is not specific a marker, meaning there are a lot of things that give you abnormal GGT. Even in the absence of liver disease. And it's not sensitive as well, meaning, there have been a lot of patients with significant liver disease and normal GGT. ALT, be honest with you, it's not much better, but it's slightly more sensitive and specific than GGT. That's why kind of, more the guidelines going after ALT rather than GGT. I still look at them both. If you order the complete metabolic panel, in some labs, GGT is included. Some other labs, they exclude the GGT for the reason we mentioned. But to answer your question, because ALT is more sensitive and specific than GGT, according to the guidelines.
Okay, maybe we can move on. I've seen fibrinogen increase, and I know you're a hepatologist, so this is really, really important. fibrinogen increased dramatically post-pandemic, post-vaccine as well. I've never seen these numbers to this degree. Maybe you want to comment on ferritin. I know that's quite broad, but these are the things I see with liver disease. I can see major changes in the sample groups, having done thousands and thousands of labs now. What's happening to fibrinogen and ferritin with liver disease and just modern day life?
Yeah, ferritin, for the audience is iron. And, I mean, there are a lot of medical conditions that give you elevated iron and elevated ferritin. One of them is hereditary hemochromatosis, which is a relatively common genetic liver disease, affects Caucasian predominantly. But also ferritin is acute phase reactant protein, meaning any inflammation in the liver or in the body for that matter, anywhere in the body will give you elevated ferritin. So make no mistake, when fat in the liver breaks down and causes inflammation, ferritin goes up. And it's not uncommon to see elevated ferritin in patients with fatty liver disease. And it turns out, actually, it's not a good prognostic factor, meaning if you do have fatty liver with elevated ferritin, you probably have inflammation in the liver. If I do liver biopsy, I'm probably going to see more damage than somebody with normal ferritin. That's kind of, my two sentences about the ferritin.
Okay. Anything on the fibrinogen that we're seeing a significant increase across the board?
Yeah, fibrinogen, I mean, almost the same kind of story, quite honestly. I would add that, fibrinogen can be, metabolized by liver. So typically, if you do have liver disease, you would expect the fibrinogen to increase as a result of that. I must admit, in the earlier stages of fatty liver disease, I haven't seen significant changes or clinically significant changes in fibrinogen. We've seen it more at the later stages of liver disease, more where you at the edge of liver cirrhosis and decompensated liver disease. That's where fibrinogen comes to mind. We take that in mind. I mean, I'm on hospital service this week. I'm currently in a hospital, and I'm gonna. When I get called to see somebody with liver cirrhosis and bleeding, fibrinogen comes to my mind right away. I need to check fibrinogen and make sure it's not low. If it's low, it's probably need to be replaced because, as you know, it helps with the clotting in these patients.
Brilliant. So, Kristin, maybe you can just take two avatars, maybe a male and female. We want to give hope to people now with regards to reversing, fatty liver disease. Yeah, what are the stories that you've got, some clinical pictures? I mean, I know you've seen patients, can people reverse this disease once they've been diagnosed with it?
Yes, as long as it's found in those first few stages. And I would even argue even in the moderate stages, right? It's not until you get to cirrhosis where it's really going to be impossible for reversal. So for the patients that I've seen, I mean, I've been a dietitian for over 20 years in integrative medicine. So of all the people I've seen, the majority of them are type 2 diabetics, or they're insulin resistant, or they're just on the edge of being insulin resistant. So from that standpoint, I always have fatty liver in the back of my mind because it's usually not in the back of my patient's mind, right? This is kind of like the forgotten disease, if you will. And in terms of the reversal process, a lot of times for me as a dietitian, my goal is to try and get blood sugar managed. So what does that look like? Well, of course, in integrative medicine, similar to functional medicine, we're going to look at the whole person. And so there's going to be a lot of aspects. I'm going to look at sleep. I'm going to look at their environment. I've even had conversations about social circles with their ability to actually engage in behavior change. But for our standpoint, it's really looking at their current diet, what can be altered in terms of overall carbohydrate content without impacting the quality of the diet. So I think that's really important. Reversal is possible, but in many ways, it's also concurrent with reversal of your blood sugar and all the dysfunction that's going on there. A lot of times, again, I'll have patients that their blood sugar might be normal, but their lipid panel is abnormal. That's a little bit more rare to see. For my patients, it's usually blood sugar. So we're going to look at moderate carb approaches, lower carb approaches. It just depends on the severity of the disease. Okay,
brilliant. Do you have any stories, Dr. Ibrahim, of someone coming in with significant fatty liver disease and they were able to, on scan as well, taking a picture, and on diagnostic labs, were able to fully reverse this disease?
Absolutely, yes. It's important to remember that this is a reversible disease early on. And that's why screening is so important. Like we said earlier, if you have metabolic risk factor, type 2 diabetes, find out if you have fatty liver disease, because if you find it early, it can be reversed. Remember, as you know, Steve, the liver has a capacity to regenerate. It's the only internal organ in the body that regenerates. And that's why fatty liver disease is reversible. Low carb diet, weight loss, metabolic risk factors, get that under control, fatty liver could go away completely.
Brilliant. So that should probably mean that anyone who's over 8 by the age of maybe 13 should get screened. Is that correct, or what is your picture?
There is no guidelines in terms of how old to screen, but if you look at the American Diabetes Association, they said anybody with type 2 diabetes should be screened for fatty liver disease. Type 2 diabetes usually doesn't affect children, it affects adults, obviously, rarely see it in children. So yeah, I mean, luckily for us, we don't see a lot of metabolic risk factors in children. And although there is, as you know, there is increased rate of obesity in children and adolescents. But as of now, type 2 diabetes, high blood pressure, high cholesterol, they're relatively uncommon in children. But in adults, make no mistake, absolutely yes.
So when should they be screened? Because I mean, we're just seeing insulin resistance, and I know there's studies, you can be insulin resistant for like 13 years before it affects your HbA1c. And for those that are listening, that's generally your 3-month average glucose. It has its sort of shortcomings. Basically, also if you've got an iron problem or ferritin problem, HbA1c can be affected. So it's not definitive, but someone can have insulin resistance for a long time. And we try and keep a fasting insulin very, very tight. If someone's overweight, who's 16 years old or obese, they've got a normal HbA1c, but the insulin is like fasting insulin is 15, 16, which can be like that for many, many years. Are we not damaging the cells to such a large degree if they're insulin resistant, and then to try and reverse that type 2 diabetes when they've been insulin resistant for many years is difficult? Should they not be screened at the age of 16 or 17 or 18? Do you have any comments on that?
I would screen them. I mean, if this is my patient, I mean, honestly, I don't see pediatrics. We see them 18 years and older. But to your point, if they have risk factors, they should be screened. Insulin resistant, measured by fasting insulin, blood level like HOMA, HOMI, or HOMA, and then if they have obesity, if they eat too much carbs, certainly if they have other metabolic risk factors, should be screened for fatty liver. Now, that being said, fatty liver disease is a slowly progressive disease. So I wouldn't expect to see a significant damage in their liver at this age. That doesn't mean they shouldn't be screened. I think it's good to know early and find the disease at early stage and reverse it, to your point, before it's too late. I would say the short answer, if you give me a patient with insulin resistance, fasting insulin blood level, obesity, I think they should be screened even at young age.
Good. Kristin, you got any comments on that?
Well, we have a whole family plan within the book, and part of having that family plan really kind of stemmed from our own experiences with our patients. I have several families that have come to me where mom and dad both have fatty liver, and then, of course, statistically speaking, the chances of the child having some sort of metabolic dysfunction are also high, and that typically ends up to be the case. So instead of just targeting the child and say, oh gosh, you have fatty liver and you're overweight and you're insulin resistant, we just do a whole family approach. Because if mom and dad are not going to buy into the approach, there's no hope for the child at that point, right? So I've seen kids as young as 8 come in with some major metabolic dysfunction, and at that point, we'll treat the whole family and hopefully get it to the point where the parents are making choices, giving by example, and the child will have the opportunity to be able to lose weight, control blood sugar, etc. But typically I don't target the kid. Again, I'm an adult, so I'm 18 plus as well, but I have had plenty of families in that situation, which is what encouraged us to say we have to have some sort of family approach here.
Okay, brilliant. So the major contributing factor to fatty liver disease is too many refined carbohydrates. And maybe you just both want to expand on that, and then we'll look at other factors that are causing, the problems with glucose control, type 2 diabetes, and insulin resistance.
Yeah, I mean, we've seen a huge increase in that. There's no doubt. We've also seen a lot of data looking at hyperpalatable foods, ultra-processed foods. So we know that all of these foods typically tend to be very high in carbohydrates. And we're not talking about the good carbs, right? Obviously, we're talking about carbohydrates that have been stripped, that have a huge impact to blood sugar and insulin. I often refer to my patients as, you don't want to have a roller coaster that's really, really steep and really, really steep down. You want more of kind of a roaring hill that's a little bit more normal, and it's less from an inflammatory standpoint. So from the refined carbohydrate standpoint, it again depends on where the severity of the disease is. For some of my patients, I just want them to moderate carbohydrates, take out really the crud that has no nutrient density, nothing tied to fiber. And that really is a great solution. And then bringing down drinking, exercising, etc. For other patients, they even have to take down healthy carbs a little bit. So just, again, it depends on how long they've had the disease. It depends on the severity. I would say for most people, we can really find a great solution simply by looking at any carbohydrate that does not have fiber attached to it, taking that out and replacing it with a healthier option. So that's really where we kind of get into the bones of things with patients, is how do we take what you're currently having? How do I take your pretzel and give you a better option that you still enjoy, that you don't feel deprived, and that you can maintain long-term?
Okay. Dr. Ibrahim, any other comments there?
I can comment on another risk factor, which is major risk factor for fatty liver, type 2 diabetes. And I will let's start by quickly telling you about a study that was done in Southern California in the diabetes clinic. It's not a liver clinic, it's a diabetes clinic. Patients were coming in to get their diabetes checked up and managed. They have no history of liver disease. They've never, ever been told that they have liver problem, right? And they have no symptoms, certainly, of liver disease. And everybody in that clinic, they said, we're going to screen you for fatty liver. We're going to do an MRI picture of the liver. It's called MR elastography, which is a fairly good test to find out if you have fatty liver disease and how much fatty liver or damage you have in your liver. So everybody got MRI. And the results were astonishing. Number one, they found that 65% of those patients have fatty liver disease. So if you do have type 2 diabetes, you're more likely than not, you have fatty liver disease. But what's really interesting from that study, 7% have significant scarring in the liver at the edge of liver cirrhosis. So on the scale of 0 to 4, with 0 is no scarring in the liver, no fibrosis, and 4 cirrhosis, they were at 7% were at stage 3 to 4. So think about that for a second. We are talking about a patient with type 2 diabetes, never ever been told that they have liver disease. They have no symptoms of liver disease, and 7% of them have cirrhosis of the liver. They've never had any problem with drinking, never had any problem with their liver, and they have cirrhosis of the liver related to fatty liver and type 2 diabetes. As a result of that study and many other studies, the American Diabetes Association came out a couple of years ago now, and they said, if you do have type 2 diabetes, you got to be screened for fatty liver, even if you have no symptoms. And screening, like we said earlier, would be blood test and picture, some kind of picture of the liver with ultrasound or MRI or something. So I think, the take-home point here, type 2 diabetes is a major risk factors for fatty liver disease, in addition to what Kristin obviously said, the increased carbs intakes and refined sugar intake.
Sure, those are frightening stats. While you're on those stats, if someone has fatty liver disease and they diagnosed it, what increased chance do they have of getting liver cancer? Because obviously cancer is exponentially increasing. I've had so many guests on the show now I had Dr. Katie Deming, a radiologist and oncologist, say about 20, 30, 50% of the population will be getting cancer in their lives. At this stage, it's 1 in 3 men and 1 in 2 women. The stats are just increasing exponentially. What are the statistics of increasing your chance of getting any cancer or liver cancers, especially if you've got fatty liver disease?
Yeah, I can take that question. Yeah, it's really unfortunate situation because fatty liver is certainly a risk factor for liver cancer and has become the leading cause of liver cancer, particularly in the Western world. And the good news, and just to be on the bright side here for a second, most patients with fatty liver disease will not get liver cancer. So a small fraction of patients with fatty liver disease will get liver cancer. So I don't want to be alarmist here. The bad news, though, is that there are so many patients out there with fatty liver disease. 25% of the world has fatty liver disease. So even though a small fraction of those patients with fatty liver will develop liver cancer, the denominator, if you will, is so big. So that's why we are seeing a lot of liver cancer, even though a small fraction, only a small fraction will develop liver cancer. And this is preventable. Like we said, fatty liver disease is a preventable disease early on. And if you get rid of fatty liver, you're certainly decreasing your odds of getting liver cancer.
I mean, fatty liver disease, from what I know, is one of the fastest growing diseases in the Western world. If that carries on increasing, say in 10 years' time, now we're looking at 1 in 3, or maybe like 40% of the population, then liver cancer rates are going to increase significantly just because of the ratios.
For sure, yeah, no, and this has been proven actually in studies published in a prestigious medical journal showing that there is significant, most studies predict a significant increase, a rise in the incidence of liver cancer in the Western world. This is unfortunate because used to be hepatitis C. Hepatitis C used to be the leading indication of liver cancer, and finally we got cured for hepatitis C. And now the prevalence of hepatitis C where I live has decreased already by 50%. And as a result of that, we started to see decline in liver cancer. And of course, fatty liver came to replace hepatitis C. And we are now seeing, again, increase in the incidence of liver cancer as a result of fatty liver.
Okay, great. Let's move on to the metabolic types. Kristin, you can answer this because sometimes you don't have to be overweight or obese or have, a huge waist circumference and still have fatty liver. So maybe go through the different stages.
Yeah, sure. So, kind of going back to our discussion, looking at the inability of BMI to predict healthiness. We have this stigma. I've seen it as a dietitian. We have this stigma that if your scale says a certain number or the BMI says a certain number, that you are deemed unhealthy. And so what we have found with the studies and the data that we comb through is that that's not always necessarily the case. So for example, one of the metabolic types is an individual that has a normal waist circumference, but their metabolic numbers may be abnormal. So hemoglobin A1C, which we've referenced a few times, or they have high blood pressure, or they have a low HDL, right? Any of those components. They are at risk for non-alcoholic fatty liver disease because of those metabolic numbers. And really, we're kind of talking about the skinny fat individual, right? So even though they might not have a waist circumference that's really worrisome, they're probably not carrying a lot of muscle. There's something going on metabolically speaking. So that would be kind of one bucket. We have individuals that we wanted to address that their waist circumference is normal, but their metabolic numbers are also normal, but perhaps they have genetic risk. We cited a study looking at individuals whose mothers had fatty liver or insulin resistance or gestational diabetes while they were in utero, and the risk to them once they were born and going into adolescence and adulthood. So their risk is a bit higher. So they might be completely normal, but a slightly higher risk because of what occurred there. Of course, then we have individuals where their metabolic numbers might be completely normal, but waist circumference is high. So not to say they're a ticking time bomb, but the chances that those numbers will start inching in a direction we don't want to see of course, is higher. And then the most aggressive plans we would have for someone high waist circumference and then high risk for any kind of component of metabolic syndrome, type 2 diabetes being one of them, which we have discussed multiple times already. So really, it's looking at the severity of who you are as a person related to your liver risk. And then based on that, how do you want to look at a dietary approach? So that's really kind of where we put everything together. The base of everything we discuss is really the base of the Mediterranean diet. There's very few studies that can beat it in terms of reversal of fibrosis and fatty liver disease. And then we just take that base and look at the carb content from there based on that metabolic type.
Brilliant. Sounds excellent. Going on to food. So what I'm hearing is a low carb or moderate carb diet. You know, we had Professor Tim Noakes on the show twice, who's been speaking about the low carb, high fat diet. I said low carb, low fat in terms of all these seed oils. I'd love to get your perspective on insulin resistance and type 2 diabetes with regards to the increased prevalence of omega-6, the low prevalence of omega-3s. We had Bill Harris on the show talk about omega-3s for the last 40 years. So I'm going to ask some questions regarding that and how important the omega-3s are, the index and the ratio is as well. But I said to Prof. Noakes, I said low carb, low fat in terms of these seed oils and omega-6s because the ratios are out. I've done over 1,000 tests now and I haven't seen someone with the correct ratio, haven't seen someone with the correct index either. And then high fat, but quality fat. So maybe you want to talk about that, which is important. And then at the same time, because I'm going to get comments on from you, one of the biggest things I try and limit in the practice is fructose, and in the form of liquid carbohydrates, just because how the liver has to cope with fructose compared to glucose. So maybe you want to comment on that, because I find the possibility of increased sort of fatty liver has come from these very quick, fast drinking sodas and fruit juices that do not have fiber, that the liver that has to then cope with this fructose.
Right. And they're coping with this the liver's overwhelmed. That's one of the words we use. And if you go back to 7-8 years ago, looking at the data on fatty liver in relation to diet, it was fructose, fructose, fructose. It was the bad guy. We know that fructose is still bad and it is rapidly absorbed. You have this huge influx of insulin. And if you're insulin resistant, you probably have a little bit more going on because there's just not enough sensitivity to assess that. But you brought up something that I talk about all the time, which is this concept of competition for digestion. So that's where I start the conversation with my patients. If you have a carbohydrate, and a drink is a great example of that, fruit juice, a cola is an obvious example. But if you have a carbohydrate with no competition for other digestion, it is so rapid and overwhelming to the body. Once you have a carb that has some sort of competition, fiber being the main source, but we could also look at protein and fat. Now the body has to really metabolize 3 different things or 2 different things. It slows that absorption. So yes, completely against any kind of liquid calorie in any type. I think where we get into the conversation, at least with my patients, is when we have this conversation, they say, oh, no problem, I'll just have diet cola. So we're good there, let's move on. All right, so the question really is, okay, well, is that any better? And I get that question all the time. Well, if I had to just drink regular cola or diet cola, what do I choose? And neither are great choices. So it's really a tricky one for patients. And I try to stay kind of more balanced, if you will. Someone says, well, I have one diet cola every week. That's it. Maybe I'm not going to touch that. I'm going to touch other things. But if this is my drink of choice, I have one for lunch, I have one for breakfast when I wake up, there are independent risks associated with that as well.
But let me just push you, Kristin, and I'm going to get Dr. Ibrahim, because I think this is very important. With regards to fatty liver and this epidemic, and I'm really concerned about this, and I think your book, I'm going to just try and push it as much as I can. If I get a hard copy, I'm going to go onto Instagram and really try and put something behind this, because I think it's crucially important. In terms of fatty liver, it is probably better to have the diet cola. You might be affecting the microbiome. That's another conversation, and we're probably going to run out of time. But in terms of overwhelming the liver with a cola and causing, that massive insulin spike, insulin resistance, and the liver having to overwork, it's probably a better option to do the diet cola and not the fruit juice, these liquid fruit juices that are causing significant problems, than a traditional cola. Is that correct?
Correct. I agree with that. And I think that's why I'm always looking for what's the amount you're having. Even something with looking at sucralose. Are you putting that in your coffee every morning and that's where you have it? Or are you putting it on your fruit throughout the day? There's a difference between the two because we know there's a dose dependent relationship when we look at risk in general. But for the liver, yes, whatever we can do to reduce the rapid increase of blood sugar into the bloodstream, and then looking at the incident of insulin, yes, absolutely. But if I have someone who's rocking diet colas every day, multiple times a day, it's impossible for me not to address that as well. Because again, I'm going to look at the whole person. But for fatty liver, absolutely. Just getting sugar out is a great idea. But let me just say this. When you have a regular intake of diet cola, it's very hard for someone who considers themselves to be a sugar addict to get off of sugar because you're still feeding your taste buds. You're still giving it what it wants. And the studies show that you'll eventually go back to the real stuff because you're constantly giving yourself that sweet. So part of limiting the sugar is limiting it in all forms when you have it coming into your diet in excess amounts. So we have to take away our addiction, and that's a whole other story, but our addiction and our prevalence to want sugar, to crave sugar. Sometimes diet products don't help with that. But again, it's dose dependent. Having some of these things every once in a while can be great. But if you're having them all day long and you just can't get through a meal without sweetness, that's when we start seeing it a little bit more problematic for behavior change.
Brilliant. Dr. Ibrahim, your comments?
Yeah, no, I 100% agree. Diet Pepsi, diet cola versus regular, it's the lesser of two evils, and just to, echo what Kristin said, honestly, when I find out that my patient with fatty liver drinks regular cola, I'll tell them to make no changes, just stop the regular soda. Because that's each can, as you know, is 50 grams of carbs, each one, 50 grams of carbs, 50. So that would be the first step. And I've seen a significant improvement in fatty liver disease just by one intervention. But it's compared between the two. If you absolutely cannot stop, soda, then go for diet. But ideally would be discontinue altogether.
Okay, some quick comments just on the omega-6s and taking those in: canola oil, corn oil, sunflower oil, soybean oil, palm oil, because I do want to get on to what people can do to reverse this. But what are your thoughts on those with regards to the diets and causing insulin resistance and type 2 diabetes?
So I limit that in my patient base. We have very heavy concentration within the book and within my own practice of extra virgin olive oil, avocado oil, even some coconut oil in some of our recipes, etc. So I think that there's a lot of data on seed oils. I think what I see in my patients is confusion over the healthier options versus the unhealthier options. So that's really the conversation that I get into in my practice. An individual will come in will say, well, not all canola oil is bad. Isn't just some of it bad? So really what I try and do is steer them towards away from the seed oils and looking at that ratio. I have started testing, not just looking at omega-3s, but that index, looking at the combination, because it's the ratio that really makes a huge difference. What is the ratio between the two? And then how do we bump up our omega-3s? Which is why we have a concentration on fatty fish oil supplementation, etc. But it is something I limit within my practice based on what I feel is pretty strong data. And I think we'll continue to see that data.
Dr. Ibrahim?
I can comment on omega-3 fatty acid. Just one quick comment here. It's a great medicine for high triglyceride. If you do have high triglyceride, which is a very common thing in people with fatty liver disease and metabolic syndrome, omega-3 fatty acid would be a very nice intervention to bring that triglyceride down. I must admit, they did study omega-3 fatty acids to treat fatty liver disease And unfortunately, it didn't work per se, like to treat fatty liver disease. It doesn't reverse fatty liver disease, but it showed an improvement in the cholesterol and triglycerides specifically panel in those individuals, which I bet, like, on the long run, it's going to help fatty liver disease.
Brilliant. Let's talk about the foods or what people can do with regards to reversing this disease.
Yeah, so what I always try and keep things a little bit more high level. I don't know about where you live, but I can tell you in the United States, I have patients coming in saying, oh, I just can't eat the amount of fruits and vegetables that the government is telling me to eat, the recommendations, our dietary recommendations. So one of the recommendations is simply to get more color and get a variety of color. We didn't get into the microbiome, but as we know, microbial diversity is one of the greatest aspects of health span, longevity, et cetera, which indirectly is going to impact our liver health as well. So I want my patients to get variety. I don't want them to just eat kale, even though kale's great. I want them to get different colors. So getting a lot of color in the diet, really trying to meet those guidelines for fiber. So increasing it. The guidelines for men are about 35 grams a day in the United States. For women, it's 25 grams. So slowly building up to that. A good aspect of fermented food and, of course, prebiotic fibers. Those are all going to be very important as well. The book is not 100% plant-based, and I think that's the fear of many people. Like, well, I like my meat. What about my meat? So I do think there is an opportunity for high-quality animal protein as well. It just depends on what the goals are and how you're deriving that. In terms of some foods that people are often surprised about, coffee, we have over a dozen studies looking at coffee and liver fibrosis, liver health. So again, if you are genetically speaking able to metabolize caffeine, you're not a slow metabolizer, then having coffee might be a great option, right? So coffee could be one of them. Berries, kiwi fruit, extra virgin olive oil, dark chocolate. These are all foods that have very strong areas within the research that show that fatty liver can be prevented or help with the reversal.
This is brilliant. So dark chocolate, your berries, your anthocyanins, polyphenols, really helping. Okay, so that's quite cool. I mean, coffee, what are you talking about? 2 cups, 2 units or 3 shots? How many? I mean, obviously it's dependent on your, autonomic nervous system, how you tolerate it, how you metabolize it. But what does possibly the research show with regards to how many units of coffee and how many sort of grams of dark chocolate? Because I know I'm going to get a lot of questions regarding that. And the percentage of dark chocolate, is it over 70% that is recommended?
Yeah. So for the coffee, typically the studies look between definitely 2.5 servings, maybe even up to 6. It just depends on the study, but I would say they're between 2 and 6. And they also found benefit with decaffeinated coffee. So there's benefit to both, right? So it begs the question, is it the caffeine or the bean? And it might be a combination of the two, right? We don't know, quite frankly. In terms of the chocolate, typically what we'll see is about 72% or greater. Once we get to 80%, it's no longer palatable and people are typically not usually wanting to consume it. So 72% is great. I think that's really important because when people see a general chocolate bar at the store that says dark chocolate, for our FDA rules, that can be 51% or greater. And we're not going to get the flavonoid benefit there. So we're just going to get a whole bunch of saturated fat and sugar and think we're doing a great thing. In terms of the studies, it's little as 1 ounce a day can be really beneficial in terms of the dark chocolate. So I think with dark chocolate, you're going to get probably, for the most case, some sugar associated with it, but a 1 ounce, you're not going to get that much and you'll get that flavonoid perspective.
Brilliant. Dr. Ibrahim, do you have anything to add there?
No, 100% agree with what Kristin said. And to your point earlier, I mean, you got to weigh other factors. Coffee is great for the liver. It's not too great for sleep. Coffee is great for the liver. It's not too great for anxiety and for high blood pressure. So one size obviously doesn't fit all. If you do have other things that could be worse with coffee, maybe cut back a little bit. That's why, like Kristin, went from 2, 2.5, all the way up to 6, because, we are genetically different and, one size doesn't fit all.
Brilliant. What about sleep? We talk about the lymphatic system really helping brain function and getting rid of all these proteins and toxins that we accumulate in the day. How important is sleep with regards to, and I'm going to put in liver detox, and I do want to talk about supplements and that. I've got some empirical evidence. I know what the research says, but let's talk about sleep and possibly even exercise. Maybe you can answer, the sleep question and the exercise sort of question separately.
Yeah, I'll take the exercise question, Kristin, if that's okay.
Yep, whatever. Yeah, so let me start with sleep. I'll start with sleep. So when we look at it, it's interesting. I just wrote an article for sleep, which forced me to look at the data that's come out in the past 2 or 3 months. So we know that lack of sleep is an independent risk factor for insulin resistance. So just even taking out of the liver detox conversation, we know it's a risk factor for insulin resistance. We know that when we lack sleep, the body literally does not have enough time to rest, if you will, to be able to recharge. And that's part of that detoxification. Ibrahim and I, we're never fans of like a liver detox phrase at all, because so many of our patients are going to like go get a juice for detox. Sleep is probably one of the best detoxifying types of things we can do for the body. When we look at the data, we see that the sweet spot is usually around 7 hours of sleep. And we also know based on the data that consistency is really important. So many of my patients, they are executives. They will be getting up very early from Monday through Friday, and then Saturday and Sunday, they're sleeping in. We know that there's negative aspect to that. So keeping your sleep consistent throughout every single day is critical, making sure you're getting those 7 hours, and then also making sure the quality of your sleep is really, really going to be the most important component. So the quality can be impacted by a lot of things. Having too much caffeine after 2 o'clock, that can impact quality, but even just the temperature in the room, the lighting, things like that. We cover all of that in the book, because we know that if you are not sleeping, neither is your liver. And if you don't give your liver a break, the detoxification that occurs system-wide will not occur at the optimal rate.
Brilliant. Dr. Ibrahim?
Yeah, with regards to exercise, I mean, obviously, as you all know, exercise is going to be, I'm going to say it's very helpful for fatty liver. It's important to note, though, that it's not as important as diet. Studies show if you focus just on exercise and you're not paying too much attention to your diet, you're not probably going to make a progress with fatty liver disease. So now, let's put the diet aside. Exercise in the setting of the right diet is very helpful for fatty liver. And on that note, I will just briefly tell you about a study that was done in Australia, where they found that if you are involved in interval training workout, about 20 to 25 minutes, 3 times a week, that was sufficient to reverse fatty liver disease. Everybody is busy. You don't have to go to the gym for an hour or 2 every day. All you need is to jump in on a treadmill or a standing bike for 20 minutes, 3 times a week, and try to do a little bit of interval workout. Go fast, get the heartbeat up, burn the calorie, and then slow down. Do it again when you're ready. Slow down, 20 minutes. You're done for the day, 3 times a week. In the right setting, that's going to be very beneficial to burn the fat in your liver.
Brilliant, brilliant. Now, I don't have a lot of experience reversing fatty liver disease with regards to the practice. I do see a lot of high liver enzymes. Some of my patients go on to do the pictures and that, and then send them off to a dietitian, nutritionist, and then go from there. But what I have found is choline. I have the liposomal form of milk thistle. I know you guys have discussed this, and the lack of science called psilocybin really help. There's obviously artichoke, dandelion, a lot of Chinese herbs and that. Tell me your experience on what has been helpful with regards to supplementation.
So I can say, before Dr. Hanouneh goes, at Cleveland Clinic, we were the first major medical institution to implement a Chinese herbal clinic. So first huge place to actually do this. So it gave me a lot of opportunity to look at some of these things. What I see right now is a lot of patients will say, well, I want to take milk thistle, or I'm going to take dandelion, all these different components. So I think number one, the more severe the patient is, the more that herb is going to interact with the medication they're on. So that's always the first thing in my mind, looking at that aspect. In terms of the benefit to the liver, we really referenced databases such as LiverTox that's run by the NIH to determine, okay, what is the risk versus benefit versus the neutrality of it. There's not a huge amount of science looking at milk thistle, but there's also not going to be anything detrimental as long as it's not interacting with a medication. So there's potential for it to benefit. But similar to what Dr. Hanouneh said related to exercise and diet, if you're taking milk thistle and dandelion and your diet sucks, it's probably not going to do anything. So the question is, how do we take all of these concurrently together? I'm fine with my patients taking things that we know will not interact negatively. But once I know that something could interact with the liver in a negative aspect, then it's a no-go. Or if the medication is going to be a concern as well in terms of the interaction and contraindications. So not a lot of data there, but it's not something I'll tell my patients absolutely don't take. It's really just based on their individual prognosis, their labs, and their medications.
Dr. Ibrahim?
Yeah, 100% agree. I mean, milk thistle have been studied in liver disease in the setting, in a very rare setting. It's mushroom poisoning. There are certain kind of mushroom that could potentially cause liver disease and liver failure. And it turns out, milk thistle could help in that rare situation. But when you take milk thistle and you study it in other forms of liver disease, like Kristin said, it's not harmful. I don't think you're doing anything wrong that's going to cause bad things to your liver. It's just, it turns out, and this is unfortunate, it didn't lead to reversal or fatty liver disease or anything.
Okay, well, just my quick empirical evidence. If I got someone with liver enzymes that are not good, phosphocholine has been beneficial, and the liposomal form of milk thistle, I haven't really found milk thistle on its own, if it's not in the liposomal form, be beneficial. But okay, so let's finish up. We're coming to the I'm running. This show has been info packed. We are going to literally have so many questions after this. You guys have been incredible. But give us a message of hope with regards to this disease. I don't see hope, unfortunately, just because of what's happening to obesity, what's happening to, I've got a 7-year-old and I've got a 19-year-old, and I just see the amount of overweight kids that are now in grade 2 with, my 7-year-old. It's exponentially increasing. And with that exponential increase is going to come significant dysfunction. I see the exponential increase in chronic disease like cancer. I don't see this, although we are trying to practice medicine 3.0 within the corporate structure, which is preventative and proactive, and do a lot of screenings before people get diagnosed. I think I need a message of hope from both of you. And at the same time, you can maybe just let people know where they can connect with you for the information.
Sure. So I think because the liver impacts pretty much every organ in the body, what I tell my patients is to let me know what their why is. We all have a why. Might be, I don't want to get dementia like my mother had. I want to get on the ground and play with my grandkids. Whatever the why is, follow that why. And that why is most likely going to benefit the liver as well. So I think when we tell someone, hit the liver, do everything for the liver, might be a little more challenging, and there could be a little less hope there. But if you really tap into how you want to be when you're 80, what you want to look like, you have the power to achieve that at any age when you start. So even if you're 50, 60, 70, and you've got all of these things going on that are wrong, you still have the power to reverse that. This is an individual thing, right? So I don't think we can rely on government or even our doctors to save our health. We have to figure out our why and save it for ourselves. That's really kind of my message.
Brilliant. Dr.
Yeah, this is a reversible disease. Your liver can regenerate. The only thing is that you got to find it early and reverse it before it gets too late. The second good news, this is a slowly progressive disease. Meaning you got some time, particularly if you find it early. on, you got some time to fix this. It's not like, you got to fix it like, overnight. Weight loss and management of diabetes, it's a long journey. And you got time to do that. And number 3, this is a disease where a wise man once said, let the food be your medicine. This is a disease that can be treated with food, with lifestyle changes. There are some medicine to treat fatty liver disease, one just approved by the FDA last week. But still, this is a disease that can be treated with food. You don't necessarily need to take medicine for it unless you need to.
Brilliant. And where can people connect with you both?
They can find me at KristinKirkpatrick.com, Kristin spelled with an I, or on social media at Fuel Well with Chrissy.
And I'm based in Minnesota, in Minneapolis, the Twin Cities. I work with a group called MNGI Digestive Health. You'll find me online, Ibrahim Hanouneh.
Brilliant. What I want to just say, I want to declare favor and blessing over you both. You're both health heroes. You're incredible people, knowledgeable. You've taken the time, you've taken the energy to write a book like this. Hopefully I can get a book and a copy here that we can then do something. Maybe, Kristin, we can talk about heart rate variability and liver disease, or, sleep, or sauna, and those type of biohacks. On Instagram, we do a live or something like that. It'll be incredible. We need more education on liver. But thank you so much. What a privilege. What a pleasure. And I tell you what, I do not have hope when I see chronic disease increase in the practice. I am seeing a therapist just to help me because I have compassion fatigue after 25 years, and my wife has really encouraged me to do that. But what I do have hope is when I meet people like you, Dr. Ibrahim, I meet people like you, Kristin, because you've taken the time to see patients, you've taken the time to write this book, and what a privilege to have met both of you.
Thank you so much. It's such an honor.
Yeah, same here. Thank you.